Hello, my name is Leanne Johnson, RN/BSN, and I'm going to be presenting on preventing solutions to mitigate workplace violence against employees in healthcare. This is an appeal to Arkansas Representative Womack to consider proposing mandated, specific, multi-interventional strategies to prevent healthcare violence. Workplace violence in healthcare is a growing public health concern and consists of physically or psychologically damaging actions that can range from physical intimidation to even homicide. Any act or threat of violence meets the definition of workplace violence and can result in serious or disabling injuries. From 2002 to 2013, incidents of serious workplace violence against healthcare workers were 4 times more common than in any other workplace and have increased 80% since 2011. 80% of this violence is from patients, and the other 20% comprises of coworkers, visitors, or other assailants. In response to the rise of violence in healthcare, OSHA posted a 2016 inquiry seeking information about healthcare violence in order to amend its existing policy. At that time, in 2015, the policy briefly suggested 5 optional strategies for violence prevention. As a result of this inquiry, Congress passed H.R. 1195, the Workplace Violence Prevention for Healthcare and Social Service Workers Act. This act instituted an interim policy for violence prevention in the healthcare sector until it can be finalized by OSHA by the year 2025. Common risk factors for violence in healthcare include encountering people with mental illnesses, people who are under the influence of drugs or who are delirious, and factors such as understaffing, high turnover rates, working alone, and the pervasive belief in healthcare that violence is tolerated and reporting is fruitless. Looking specifically at nurses, the consequences of healthcare-related violence results in increases in nurse turnover rates and increases in injuries. So this exacerbates the nursing shortage, and this also perpetuates violence, poorer patient outcomes, and higher healthcare costs all around. As reported in 2021, it costs $28,000 to $51,000 to replace a single nurse. This incurs up to $6.5 million in losses annually. In fact, for each percent in nurse turnover or retention, the organization can either lose or save an additional $270,000. So back to H.R. 1195. Progress has been made towards standardizing violence prevention laws in the healthcare sector thus far. But what I would like to discuss and propose are multi-level violence prevention options for future healthcare policies. 2 approaches to staff training exist. One approach is to use standalone training like annual awareness workshops. The second is structured training activities, and this involves multi-week training sessions using cognitive rehearsal programming, which is practicing communication skills, and role-playing scenarios. So although 8-hour standalone training does increase staff confidence in dealing with violent situations and disruptive coworkers, it does also improve turnover rates. However, what it doesn't actually do is prevent violence or encourage safe reporting practices. However, structured education using de-escalation training both increase staff's ability to identify and respond to workplace aggression before it becomes problematic. It was proven after 203 workshops over 3 years with 4,000 participants that verbal abuse decreased 20%. Effective multi-level prevention plans use environmental interventions such as panic buttons and automatic locking devices, and administrative interventions like written policies and procedures. And this is also coupled with behavioral training for managing actual violent situations. Stakeholder involvement alone can result in an 81% increase in implementing these multi-component strategies. Additionally, measures such as risk identification, safe reporting systems with specific policy and procedures especially decrease the rates of threats and assaults. So without stakeholder involvement, implementing an alert system to identify high-risk patients for violence upon admission, coupled with the staff education and training, is also a viable option to significantly reduce the rates of violence in this population as well. So what has been tried in the past are, other than standalone training, are single name ID badges and increased penalties for assault. While this does not actually prevent violence from occurring, when pieced together with other interventions, specifically stakeholder buy-in, there is a proven reduction in violence rates. So based on this information, the recommended policy options would include comprehensive combination interventions with structured education, like stakeholder buy-in, safe staffing, risk identification, reporting policies, and panic buttons and system alerts for the potential offenders. The main goal and benefit of violence prevention are eliminating injury and disability and also its cost to the individual and healthcare system. In 2016, the cost for disability from violence was estimated to be $4.8 billion, of which $752 million was unreimbursed or under-reimbursed. So initially, the cost to implement my version of HR 1195 will be about $70 million over a decade, with subsequent maintenance being less costly. So compared to the cost of disability from violence, the $4.8 billion, preventing violence far exceeds the consequences of non-prevention. Workplace violence in healthcare is devastating and escalating in the U.S. Efforts by OSHA and Congress have created an opportunity to improve the culture of American healthcare. Hopefully, the options presented here can serve as a prototype to keep healthcare workers safe and the public healthy. Thank you very much.